Morning everybody, it's Tomkinson here from Kernow Physio, and this morning's topic we're going to talk about anterior shoulder pain, rotator cuff injuries. Now we're going to talk about the consequences of our shoulders, what they can do, and the associated risks because of the anatomy of this. Here's the shoulder, this is your scapula or shoulder blade, this is your arm bone here. Now we're going to talk about the supraspinatus tendon. Here's your spine of scapula here, and the supraspinatus attaches here. There's the muscle belly. It has to come underneath your collarbone and then down onto the front of your shoulder. Now, here's my finger. This is going to demonstrate or be an illustration of a supraspinatus tendon. It has to get underneath that collarbone and get up into here, and then as you bring your arm up, the risks are you can impinge the tendon as it's coming underneath this collarbone. Now, the problem is, a lot of health professionals and patients that I've seen, the rehab has been focused purely on this tendon. Now, this shoulder blade here, we now know from evidence, needs to be in the right place. And we're going to talk about that in the next video, or after the next video that you're going to see this clip of a patient that's struggling with this. Now, look at what I just said previously, joint space is quite compromised anyway. If this shoulder blade isn't in the right spot, you'll now see the after effects of that in the next clip. Yeah, so have a look at this patient's arm and his shoulder blade on the right hand side. Initially he came to see me with anterior shoulder pain here, and he had a supraspinatus tendon inflammation. Previous physiotherapists have just focused on rehabbing his shoulder in terms of the supraspinatus. Lots of band work, doing this with a band, lots and lots of this. But having done the Joe Gibson shoulder course a few years ago, we now understand the importance of the actual shoulder blade. If you look at his shoulder blade, instead of being flush with the rib cage, it's actually elevated or protracted this way, and it's up. When he moves his arm out to the side, it literally goes straight up and then comes round at the end. In order for the shoulder blade to function, the shoulder blade needs to go around the rib cage and then up. If you look at his shoulder blade, it's winging, it's restricted, and then it goes around at the very end, at the last minute. As a consequence, you're then compressing this joint space in the front of your shoulder for the supraspinatus to travel through. In addition, this patient actually has had a stroke, and his vascular accident has caused a bit of a right-sided weakness. So he's seen other physiotherapists, he's had massages to the nth degree, they just massaged here, and acupuncture. The reality is, his right shoulder blade, if you look at it, it's really unstable. He had a really tight upper trap, because your arm is a limb. You know, our arms are quite heavy and they need support. And the reason why the shoulder blade is so big and triangular and flat is it forms muscular attachment. And we need to keep the shoulder blade in the right position, so when you move and stabilise the shoulder blade, you don't end up with a rotator cuff injury. So my point is here, you need to look at subjective information. You need to really assess the patient. He's had a previous stroke, and just doing this doesn't work. It's very blinkered. You need to look at shoulders as a whole, and you can clearly see that shoulder blade isn't functioning. So we've done lots of rear cuff work, lots of shoulder blade setting, and now we're avoiding cortisone injections and everything else, and we're seeing benefits, we're seeing progress. He's had this injury for 4 months. He was struggling to put on jackets, you know, they were looking at surgery, but if you stabilise the shoulder blade and work on shoulder blade function, it leads to good outcome.